I'm Dr. Mark Gold, and this is the Gold Standard.
It is such a pleasure to welcome Dr. Bertha Madras here to the Gold Standard. She's a great friend, leader in the field for decades. Honestly, for 40 or more years. I lost count, but welcome.
Thank you. Well, I started graduate work on hallucinogens in 1963. I was very young. I finished my PhD at 3 years, and I finished college in my teens.
Gee, you were on some accelerated path. Do they have that in Canada?
I was on an accelerated path, not deliberately or not institutionally. And then I slowed way down because I had 2 children and took 3.5 years off for each one and completely dropped out of sight until I felt they could be a little bit more independent.
Well, that's maybe that's an interesting pathway. I've always had this theory that early pregnancies actually cause the spurt in brain activity that creates a different, if you would, person than the person who had never had a child.
Yes.
There's a tremendous. Well, you're a neurobiologist. I'm speaking to someone who probably has a similar theory, but there's this tremendous growth in brain and change in brain activity, and maybe even makes female gender who've had children have different brains than female gender who haven't.
Well, I think one of the most important, there are 2 changes that I felt happened with early childbirth, and one was that it accelerates maturation and commitment to the next generation that is profoundly different, I think, without having the experience. Because I think of the way I thought before I had children and after. And from my perspective, especially with drug policy, it was to embrace them and protect them at all costs from drugs. So I think that that's one accelerant of having a child. The second accelerant is that you learn that there is so much time that you don't have to race ahead with your career. And above all, spend those precious early years with the child and give them the best possible launch pad in life. And I adhere to that principle as well. At least the best from my perspective. I hope the kids feel the same way.
Well, you do never know. I actually didn't even think of that when I was preparing. I went through what I thought were your major contributions, but I didn't even properly introduce you. You're professor of psychobiology at the Harvard Medical School, professor at McLean. And is that your lab still functioning?
I closed my lab last year because I just felt that it's time for a new generation. I'm still involved actively in writing papers, in catching up with all the data that I've had accumulated, which would take me another decade to write up everything properly. So I have a lot of basic biology left to publish, and now it's time to catch up.
It's great. I'm looking forward to it. I try to read most everything you've written, and I'll try not to bore you with what I think your greatest hits are. But before I get into those contributions, on your CV, there's just so much. There's public service, there's teaching, there's research, there are inventions and patents, there's, bringing science to light for people in museums. But,
yes.
There's the Vatican. So what was the Vatican in 2017? And how did your Pontifical Academy of Sciences, how'd that come about? And what was the result of that?
Well, the chancellor of the Vatican Pontifical Academy of Sciences has weekly or bi-weekly sessions in which he invites scientists with some core expertise to a panel discussion on what they consider major public health concerns. And this was certainly true during Pope Francis's time. The chancellor, who was Marcello Sorondo at the time, he's retired now, was an absolutely wonderful man, open to ideas. And he invited a group of us, including Jonathan Calkins, Nora Volko, Kevin Sabet, myself, from the US, and a contingent from Sweden, from the UK, from South America, particularly Argentina, where he was from, but other countries as well, to convene and develop a statement, which they always end up with at the end of the week. The charge is to develop a stance on public policy related to a public challenge. You know, sometimes it's kidney donations. There are many different topics. And this was, what should the world do about, and how should they view narcotics? And in the end, we developed a statement, and Marcello Sorondo called me and said, we have everyone wanting to make their final statement on this. And he said, we're not getting anywhere with a conclusion. You and I, let's just do the statement together with input from the Pope and from all of the speakers who were present. Let's try to summarize it in a facile and accessible way. And that's what we did. So he and I just went back and forth and wrote the final statement, in which we said that drug use is a massive public health and criminal problem. It is, it compromises families, it compromises youth, it compromises the health and well-being of multiple people. It should be avoided at all costs. Government should not support the marketing, the promotion, the sale, the legalization of any drugs. Mm-hmm. And it was a pretty unequivocal, definitive statement, which I was actually very supportive of. And we all shook hands. We met the Pope. He presided over one of our major sessions and gave a speech. And I remember one of his pivotal comments saying that drug addiction is a modern form of slavery, which I had not conceived of in that way, but clear, because that kind of what I call hyperbole, I could never teach to medical students or to scientists, and yet it's a vivid way of putting it.
Well, it may have influenced Bob Dupont. I don't know when, but he had a book, Chemical Slavery.
I don't know if it was parallel thinking, but I raised it with Bob. I said, I heard that from the Pope.
What did he say? Great minds think alike?
I said, you and the Pope are in complete agreement. And we had a good chuckle over it, but it is a vivid way of what you learn, and certainly in government service, is that you have to present things in a fairly dramatic and vivid way to get a point across. I had to go through media training 3 times, because every time they would ask a question, that a media person would shove a microphone in my face and say, what do you think? I would always answer with, on the one hand, on the other hand, this is the data, and how far can we extrapolate from the data? And they would go crazy and say, please, that's not for the public.
It's more like as a professor. But you were a great professor. And, when I think back of your work, non-human primate work, and your imaging work at Harvard and McLean, one of the things that always, that I relate to and have have used many times in my own thinking is your work on critical periods, that drug use in children and developing people is not the same as drug use among older and fully mature people. And I don't know when when your first article appeared, but it had to be in the 80s sometime.
Yeah, it was early on. I always felt that kids are much more vulnerable just by observation, not by the actual biochemistry, because that came that came very forcefully home when I actually did the studies. But I remember in my era, there was almost no drug use. The very rare kids that started using drugs got into such deep trouble so quickly in terms of losing interest in school, in terms of copping out, failing exams when they were very bright. And I said, I don't see the same parallel effects in mature adults to the same. Of course, it happens. You know, people lose their jobs, they become homeless. Adults can suffer terrible consequences. But I found the kids simply lost the sense of hope for the future. And I said, there's something about their brains that are different because their goals have just been derailed and their motivation, it seems to have been compromised. And so I began to talk about it, especially when I was at ONDCP, but long before that. And when I was at ONDCP, it just became much more vivid because I had parents literally, not figuratively, clawing at my arms. One person literally just about skinned me, begging me to get their child into treatment because their child was lost. And there were two lessons I learned from that. One, it's clear that addiction can be very severe in young people, and the consequences to their entire quality of life can be equally severe. But it also has a dreadful impact on the family. I have met parents that have said the thing that nobody talks about is that the family loses hope. It loses that sense of unity, of hope for the children, of a family coherence and cohesion. All you think about is when is the next misstep, when is the next disaster that siblings and parents and grandparents have to deal with. And so I began to do research in the lab. And our first approach was to look at just behaviors induced by psychostimulants, by MDMA, by methamphetamine at different age groups. And every time psychiatrists would present in grand rounds something about, the consequences of drugs, I would say, what is the age of onset? And they would never know the answer because they hadn't thought of it. And that was my refrain. It was never a gotcha question. It was, please think about age of onset, because that is one of the variables that was ignored in the literature. So we found tremendous differences just in terms of motor behavior and all that between the two age cohorts. But then we looked, for example, the neurotoxic effects of methamphetamine and found that the neurotoxicity of methamphetamine on dopamine neurons was much more severe in the adolescent mouse rat compared to the adult. Exactly the same dose on a milligram per kilogram basis. And I said, what is happening? What is the case? And then we went on to look at THC as well and found, and this was just published last year, we found that THC affects astrocytes, glia. It actually promotes an inflammatory response in adolescents, primates, and rats that it does not do in adults. in the amygdala, which is one of the most critical brain regions for survival instincts, for depression, for sleep disorders, for facial recognition. There's a whole slew of survival qualities that are embedded in the amygdala. And that was the only brain region we found this inflammatory response, and only in the adolescent. And at that point, I said, this has to be life work.
It's really, really important and helped change the field. I used or channeled that research in helping Kevin Hill write the editorial in the American Journal this month.
That was a gorgeous, gorgeous, gorgeous paper that you co-authored with him. It summarized everything that people needed to know. And I've been battling this, with the Department of Justice. I was the expert witness, the sole one for rescheduling marijuana in 2014 in the Eastern District of California. And I literally read every single paper on medical uses of marijuana that were reasonable trials. Reasonable means N equals 6.
We had a control group, maybe.
As opposed to N equals 1,000. And every single one of them came up with insufficient. And I was the voice in that trial of saying the data just aren't there. But you put it all together with Kevin. It was beautiful.
Thanks. You often were alone in saying that. So you were pretty much alone before the ABCD study on the age-specific effects, the age-specific risks. And when you look at that data and my analysis of it, the prevention message in our era and Mrs. Reagan and Carter and before was always should wait until the brain matured. And that was about 21, maybe for females and maybe 25 for males. And now you have ABCD data that says, hold on a second, the brain's not even fully there at 30.
That's right. Well, it's interesting because the proceedings of the National Academy asked me to write just a commentary on a paper that Nora Volkow had put out on dopamine release in people who were chronic marijuana users. And in it, I wrote that we need longitudinal studies that begin at the very earliest ages and follow them so that we can settle the mess of whether or not this is causation or association. And Nora called me after the commentary was published and she said, Bertha, you put in this little note about longitudinal studies. I said, yes. She said, guess what? We're going to do it because we had thought about it, before your commentary came out. I said, that's wonderful, because I said causation versus association is used consistently to deny, to denigrate the negative consequences of all drugs.
But even with the most definitive data, and certainly you could say, I'm a professor at Harvard, I'm a neurobiologist, I've done research in the field for 30 years. Cannabis is not a harmless drug. It's likely to change the developmental trajectory of young people. What could someone say against that other than it helped my grandmother?
That's right. Well, I always say I never deny a personal anecdote, but I always say public policy, FDA's approval, and anything that we do in the court of law is simply, if it's public policy, it's just not going to be based on anecdotes. It has to be based on hard, cold, high quality research data. So somebody says that my pain went away, it'll relieve. I say, I'm not denying that, but that's not how policy is made.
So, that's what everyone loves about you. It's the data, and stick to the data. And I even have a hat that one of my grandchildren made for me that says science. And you don't go wrong by abiding by the science. But you were at Harvard, and they had plenty of people that probably objected to your research and your prevention stance.
Well, it was interesting because there are some people who are very, very supportive, and there are others who stay away, so to speak, because and some people have switched sides. There are people who literally came out in publications against what I said and my own policy perspectives, and they're completely now in my corner. I shouldn't say it's my corner; it's the corner of public health and data-driven evidence. So I think eventually, I've told Kevin Sabbath this many times because he used to question whether or not science really has, whether or not you get to the public with science. And I said, Kevin, it's all going to come down to that.
Definitely.
That's what evidence is. It comes down to that in a court of law. It comes down to that in terms of FDA. It comes down to that in terms of what government should or should not do. They're not necessarily doing the right thing. But in the end, this is the measure by which they will be assessed. They will be viewed by historians.
I've had that conversation with him many times, and even in the JAMA review that you talked about, I sent it to him, and he basically said, well, that's another paper. And the American Psychiatric Association had asked me maybe 2 years before that to look at, they had a council on therapeutics and to look at all the controlled studies like you did. So here for the JAMA paper, we literally took a full year looking at, and we have charts of all of them, of all of the studies. And I said, Kevin, the point of it is just look from the point of view of science at the evidence as if it was a medicine. People could still vote that it's a recreational substance, but you would like the FDA to stand for safety, efficacy, comparable efficacy, and an outcome in a specific disease. You're not going to go wrong by dying on that hill.
You're never going to go. I wrote, the World Health Organization commissioned me to write an update on cannabis as a medicine. That was 2014 also. And I did that excavation of all the randomized controlled trials. I looked at individual cannabinoids versus smoked cannabis. And I came to, a conclusion certainly 10 years ago that there was nothing there. There may have been a little bit of evidence for chemotherapy-induced nausea and for AIDS wasting. But even at that time, there were already alternatives that were safer. And when I presented it at the WHO meeting, there were people who were ready to throw me into Lake Lucerne, or whatever the lake was that the headquarters was.
Lake Geneva.
They were so angry, especially people from Holland, from the Netherlands, people where it was a massive industry. And I always have said, if it's profit, politics have to stay out of public health, period, especially with drug policy. And profit and politics are intimately bound up with drug policy, unfortunately.
Unfortunately. Well, I mentioned a little bit about your public service, and you've won Knight of Public Service Awards, but better than that, and even better than your museum exhibit, which my children got to see when they were
Really?
Oh yeah. Even better than that, you somehow managed to get a course at Harvard on addiction. Like that all by itself. I mean, that's in the Lester era.
The Lester era, absolutely. It's an interesting story. Dan Tosteson was the dean of the medical school, and he had been approached by two very prominent, very wealthy men who were involved in some obvious businesses that I won't mention, but they were people would know who they are. And they said that their children had gotten into deep trouble with drugs. And every doctor they went to was totally incompetent, insensitive, and completely unaware of what to do about it. So Steve Hyman, who at that time was also at the medical school, he and I, the dean called us both into his office to talk about what we should do. And the first thing I did was somebody brought in a service of tea with cookies, and I started to serve it. And Tosteson went crazy. And he said, no, no, no. We don't want role models of women serving us tea. I said, it's my instinct. I'm sorry. But putting that aside, he pointed his finger at me and he said, you're going to start a course on this. And I remember putting out a first draft of listing all the drugs and what we would say about them and all that. And Dan Tosteson said, that's just not how we teach it at Harvard. It's not didactic, it's case method and all this. And I said, well, I'm going to make this different. And one of the things that I did was bring in the Federation of State Medical Boards, the Physicians' Health Services. I brought them to treatment centers. I brought them to detox centers, the students. I brought in the DEA and said, what does the DEA expect of your license? I brought in the licensing board. What do they expect? And the course had so many different angles. It was, I started with, it was an elective course. I just wanted a few medical students, but soon it blossomed, and we had a lot of students very interested in it. So it was quite successful. And then Washington called, and that too was completely unplanned. And the course died because I had to give up everything.
Like you give up everything to be the drug czar.
I gave up all my grants, all my students, all my postdocs, the technicians. I had a lab of close to 20 people gone. I gave up the teaching. I gave up editorial writing. All of my presentations that I had, about 20 lined up for the year on the biology of drugs, which I always loved speaking about, and all gone. I gave it all up. And recreating that was very challenging after I came back.
Well, for sure. I mean, but I don't think most people would know that when you came up for a vote, you were 99-0. Is that right? Or is it, where was that one person?
That person was just absent because I think they couldn't make the vote.
But I mean, you'd think that someone who had such public views on drugs and drug policy would at least have someone against you. I mean,
I was actually, first of all, I didn't know it was coming to a vote. I had been voted out of committee onto the floor. And then I was recess appointed at the beginning because Senator Grassley put a hold on me and the supply side guy, James O'Gara. So I was demand side, he was supply side, and Grassley did not. He had some issues with John Walters, and he just would not allow a vote. So I was chugging along as a recess appointee, which meant only about a year or so, and very worried because by that time I had 120 priorities to accomplish every year that I was there. I had lined them up. And one night I'm in California doing a session with Kaiser Permanente on their data, because they had wonderful data on the consequences of substance use for medical problems and also family problems, family medical problems. And I wanted to know how they got the data so I could think about how to exploit that. And I get a call from Walters saying that the committee's voting for you tonight. And I said, what? No warning. And I get a second call. It's 99-0. I said, what? So, and he said, the only reason it's 99-0 is that you have no real history of being political in this world. And I said, I sure don't.
I mean, it is remarkable. Am I just making it up, or is it is that remarkable?
Well, it was 99 and at that time, the House and the Senate was almost as viscerally divided as it is now.
That was under George Bush.
George Bush 43,
yeah.
Yes. And the Speaker of the House, who I met once, told me he has never seen such acrimony in his life between Democrats and Republicans. And I was so apolitical. I did not know what he said when Tip O'Neill was here, and he kept giving examples of how they all used to go out for beers. And he said, no longer, they just dislike each other intensely. And I said, it's just not the way to. I said, these people are supposed to be here for the best of the country, not for personal animus.
So you had a list of things you'd like to do. And, from the clinician side, you as a translational basic scientist, and then translating science for the public and public service. Your public service side was really a lot about clinical care.
Yes.
It was amazing to me because I'm going I would have liked to do that. Brief intervention, evaluation, diagnosis, reimbursement for addiction as a disease. Maybe there are other highlights, but those would be SBIRT. Those would be my highlights, and they're clinical highlights.
Yeah.
You cared about the person with addiction very much, and that they were somehow forgotten in everything.
Well, the screening and brief intervention referral to treatment, from my perspective, covered the full spectrum of prevention and treatment and intervention. And the way I latched onto it, I had no idea that this was a project, that the federal government had a few states where they were doing pilot studies. But I remember saying, what can I do in such a short period of time? Because once the president is out of office, it's over. So I looked at all the portfolio of all the grants and all the programs that SAMHSA was running, that NIDA was running. And I convened a meeting at SAMHSA, and I said, I want to look at outcomes, for recovery support services, for treatment services, and for SBIRT. They had ATR, all these acronyms. I said, I just want to see what the data is. Do you have outcome data? And they gave me a list of all the different programs and the outcomes. And this one, Wilson Compton from NIDA was there, Jack Stein was there, and Tom Stegbauer were there. And I looked at the data. They just handed me literally a sheet of about 300 pages of data. And I started to fish through it, and I said, oh, wow, what are we sitting on here for? I said, this data, these outcomes are great. I said, they may not be randomized controlled trials. They're not going to be the same rigor as you would do in an academic research project or pharma does to evaluate a drug. But I said, the trends are just terrific. I said, this is what we have to focus on. And they said, I said, the first thing we're going to do is publish. So I called Nora and I said, Nora, get me some people from epidemiologists and from SAMHSA, put them all together. I want to write a paper and I want to make sure that I'm not monkeying with the stats, because you always know if you torture the data enough, they confess. I said, I want third people independent from me to look at it, because my eyes are just bulging at how good it looks. And I wrote the paper with Wilson, Compton, and Jack, and Wesley Clark. And from while I was writing it, I was already working on billing codes. I said, what's this? I said, let's put on a business model. What is the obstacles to having physicians do this? The first thing that came up was time and money, which is and I said, we've got to get the AMA and CMS to approve billing codes and reimbursement. And so I called the AMA. I called the headquarters in Chicago, and I said, I want to visit you. I went to visit them, and I said, I want you to be involved in this, in screening brief. And they said, look, we do tobacco, we do alcohol, leave us alone. We have enough trouble with that, let alone all drugs. And I said, Mike Maves was the president at the time, and Richard Yost was there. And I said, but what about prescription drugs? Isn't that your bailiwick? And we have 6,000 deaths due to overdoses of prescription opioids. And Mike Maves, he just stopped dead. He slammed his hand on the desk, and I thought he's going to throw me out. I was so frightened. He said, Bertha, you're now talking to my language. He said, we're going to help you in every way possible. And so when the AMA CPT board came up, they called me immediately and said, come and present your case, and we'll see if we can help you get these billing codes. That was it.
That was a first, really. And it's also just brilliant because you understand how the system works. It's one thing to have a great idea, but the implementation requires use of existing systems.
That's right. And what I did was do a systems analysis of all the obstacles. The RUC values for the billing codes, every one of these, I was learning on the fly, literally on the fly. I'd never heard of a billing code before.
Well, it doesn't come up often.
It doesn't come up. When you're studying dopamine transporters, exactly, or RNA transcriptomics, billing codes don't come up. Really. And so I learned. I had one of the people was helping me. He was telling me what the billing codes are, and I said, well, he helped me prepare these petition for the CPT. They turned us down the first time. That was in 2006. And they turned us down, and this was the reason. They said, we have enough with tobacco and alcohol. We don't want to talk about jogaholics, sexaholics, computerholics, gamblingholics. As physicians, we don't want to deal with this. And they turned me down flat. And I called again to the CPT board chair, and I said, look, I'm going to be out of here in no more than 18 months. And I don't know if there'll be somebody who will champion this. So can you just put us back on the docket for the next session, which is 6 months from now instead of a year? And they said yes. And at that point, I came in there the second time. And I said, gamblingaholics, sexaholics, chickaholics, you name it, they don't cause medical problems. Drugs do. They can cause psychosis. They can exacerbate diseases. They can interfere with pharmaceutical medications. I went through the whole hierarchy of how drugs can affect the health of the patient. And it was passed. And I got a CMS, I petitioned for H&G codes. I got those before the CPT. But everybody, all the state directors, state Medicaid, Medicare directors said, if we have H&G codes, it's not enough. We've got to get the CPT. So that's what that was my goal.
Well, you certainly achieved that. And what do you think the major accomplishments that you had as drug czar?
Well, as deputy drug czar for demanding. I think putting screening and brief intervention and referral to treatment. My goal, as I said, actually the first month I was there is I want to medicalize substance use and addictions.
I think you did that too. Yeah.
I remember saying that so specifically because when I was teaching the medical students, I realized they learned nothing. They knew nothing about this. They knew how to say, are you smoking? You stop smoking. It's not good for you. Are you drinking too much? Stop drinking. They didn't know how to refer. They didn't know what detox was. They thought detox is treatment. And because I spent quite a long time, it was almost 15 years teaching to medical students about addictions. So I said, we've got to medicalize this because, and I'm not going to be cruel or politically incorrect, but I will say that the conventional treatment without the rigor that medicine imposes on physicians of accountability, of record keeping, all of that was missing in the treatment system and evidence-based.
Definitely.
Can I give you an anecdote of evidence-based? Because this is the best. So I went to a lot of treatment centers throughout the country to look at what non-medical treatment was like. I shouldn't say non-medical, but non-medical criteria and standards, what it was like. One of them was in New Mexico. And I went into a little treatment center that was funded by our tax dollars through SAMHSA, through the block grants. And I said to the woman, where are your records of how many people you've treated, how long whether or not they come in after being referred, how long they stay, do they complete treatment, what are your follow-ups? And I said, what about relapse? What do you do? And she said, oh, we don't keep records. We just let people come in, we treat them. And she says, we have no relapse. He said, no relapse. I said, that is a miracle. How do you accomplish the miracle? I wasn't being facetious. I was eager to learn. She said, every week on Monday morning, I drive across the border to Mexico. There's a little village there that creates an extract of a cactus plant, and they mix it with a cream, a very oily cream from lanolin from sheep, and I rub it on the hands of all the people who come through our treatment, and they never relapse because I rubbed this cactus on them. I came back to Washington and I said, we're going to medicalize. I said, this is completely and totally insanity. Now, I still believe that spiritualism helps people. And maybe you believe in the placebo of the hand cream. But I did not buy it without records, without medical records, without any kind of documentation.
Well, you definitely changed a lot when you were in Washington. I think addiction as a disease is firmly established. The need for brief intervention and referral to treatment firmly established. The need for coding record keeping firmly established. And you even took it a step further. You sided with insurance coverage. Not only have codes, you said we need reimbursement.
Absolutely. And the RUC committee bothered me terribly because when they set the reimbursement levels, I knew they weren't competitive. And I knew from their perspective, it's like, forgive me for saying it's the socialist view of the pizza. Instead of making a bigger and bigger pizza, you just cut the pizza smaller and smaller. They didn't want to share reimbursement for other forms of medicine, especially they didn't want to share it with psychiatry and I said, this is 20 to 30% of our population needs these services. That's much higher than almost any other disease. And I could not win that battle. I tried hard, but they put the reimbursement levels too low. And so I thought of an alternative, and that was to develop a cadre of behaviorists who would be reimbursed at a lower rate than a physician who's done 8 years of intensive training post-baccalaureate. And I tried to advocate for that, but I ran out of time.
Well, you didn't run out of time in DC because you came back to help be a member of the National Advisory Committee on the opioid crisis.
Yeah, on the opioid commission. I came back and I worked with 3 governors, Charlie Baker, Cooper, and Chris Christie, Patrick Kennedy, former congressman, and Attorney General of Florida, Pam Bondi at the time. And Chris Christie asked me to write the commission report. And I wrote, if you look at it carefully, ONDCP helped enormously with budget issues and all that. I wrote about 65 to 70%. And Patrick Kennedy included the parody because that was his dad's thing. But it was a very good time because the interesting thing is that President Trump accepted and supported it 100%. And when he passed the bill in 2018, the Support Act, which was almost $8 billion towards it, it had many, many parallels with the commission report, and that felt very good.
Well, it was just a huge contribution because at that time, the field was actually arguing with each other, with one another, about what would be the appropriate response to the opioid crisis.
Well, there were many things that I literally pulled out of whole cloth. One was, dissemination of naloxone was critical.
Definitely.
The warm handoff. I just thought, when I read the data, that half of about 5% of the people who are rescued
continuing treatment.
They go back into overdose within a few months. And I wanted warm handoffs. I was making it up. So the other thing I remember is how crazy the CDC data acquisition was. It was 2-year lapse.
Right.
All our data was lapse. So I called my son-in-law and I said, do you know anybody who's really good in data analytics? Because he was quite knowledgeable. And he said, there's a company called Palantir that does real-time data. So I called them up and I said, please, I want to meet with you. They sent up a whole party and I met them at the Mass General in the cafeteria because I was downtown that day. And I said, show me what you can do in terms of real time. And they opened their computers and showed me the numbers changing in real time. And I said, that's what we need for all our data, for overdose deaths, for criminal behavior, for use rates. We need real time. So that was put into every single recommendation, real time data. And then I wanted to know what we can do in research. So the whole thing came together.
Well, I was just really proud because when you first look at that commission, you don't see anybody that could actually figure out how to undo the opioid crisis. And everyone was relying on you. And of course, you came through.
Well, thank you. I'll tell you, Roger Weiss at McLean Hospital, Hillary Connery, and Shelley Greenfield,
Mm-hmm.
Who run essentially
Sure,
the
I know.
addiction services. They're wonderful people. I said to them when I first got the appointment, I said, I want to hold a meeting at McLean. Can you help me? Where I can meet the families of people with addiction and hear from them what's wrong with the response. Because we never listen to the families. We listen to the patients themselves. And they came up with really wonderful complaints. For example, if there was a slot in 20 miles away from Medford, they were sent there, and the next time if they had a relapse, they were sent to Somerville or to Worcester, where there's a slot without any continuity of care. And so that went into the report. I was listening to what they felt were, and they said, we as family are completely excluded because of age of majority. It's our children. We love them. We don't want them to die, but we're not involved at all in their care. So I shoved a little bit of that into the report.
Well, it was just great that so much of it was adopted. And obviously, we're benefiting right now by the huge reductions in overdose deaths and other aspects of your public policy contributions to help us with this national scourge.
Well, Mark, may I add one little personal anecdote to it? It seems that everything good that happens when I'm holding a grandchild. Because I was on my way to Austin to visit my family, my daughter and her husband and grandchild that were living there. And little boy absolutely was wrapped up with us, with grandparents. And he always met us at the airport. And the minute he would meet us, he'd jump into my arms and just hold my neck so tight. And so I came down the escalator and he saw me. He ran in, and just as he grabbed onto me and I held him, the phone rings and it's the White House saying, President Bush is going to announce your nomination today. And they say, here is the wording of the nomination. We'd like you to approve it. And this little child is muttering and sweetly whispering things. And I refused to let go of him. And I said, I was listening, yes, yes, yes. And I said, all the wording is perfect. Thank you very much. Then when Chris Christie called to ask me to usher and write and, supervise the whole report, I was holding another grandchild at the Edaville Railroad on Labor Day. And he calls and he says, Bertha, we've decided it's got to be you. I said, thank you. So everything good happens when I'm holding a grandchild.
Well, it's just what a remarkable life. So many hats, always just a tremendous career, and sharing your life in balance as a wife, mother, grandmother, scientist, and pioneering addiction prevention and treatment expert. What a pleasure to know you, and we're all proud. And thank you for sharing that with us here at the Gold Standard.
Well, thank you so much, Mark, for I rarely in my past have talked about these adventures because I don't think they're important. What's important is the outcome. And so having a chance to share a few anecdotes is a pleasure. There's just two final thoughts may I conclude with. One is my mentoring of kids in astronomy and in science is something that is rarely known, or I don't talk to anybody about it. But in December of 2025, the International Astronomical Union named an asteroid after me.
Oh, that's great.
And that was because of
That
mentoring.
might last longer than the rest of us.
That's good. But that was after the mentoring. And the final concluding statement is, I've never subscribed to a war on drugs. I always have believed that the brain, and I say this over and over, it's the repository of our humanity. It's what makes us so unique on planet Earth. And I think what we're waging is a defense of our brain, which is the repository of our humanity. And that's how I feel and will always feel.
Well, thank you again for everything. I can't list it all. Thank you for your friendship, and thank you for being here with us at the Gold Standard.
Thank you so much for having me and listening to my blabbing away.
It wasn't like that at all.